Porphyria disorders of heme synthesis, clinical presentation, diagnosis, and management. Porphyria disorders affect an estimated 1-2 per 100,000 individuals worldwide, with acute intermittent porphyria, AIP, accounting for 70% of cases. Pathogenic accumulation of porphyrin precursors such as delta-aminolevulinic acid, ALA, and porphobilinogen, PBG, results from enzyme deficiencies in the heme biosynthetic pathway. Diagnosis hinges on quantitative urine PBG, 2 mg/24H, and plasma ALA, 5 mol/L, measured during an acute attack, supplemented by genetic sequencing of the HMBS, CPOX, PPOX, or UROS genes. First-line therapy with intravenous hemin, 3 mg per kilogram Q24H for 4 days, combined with high carbohydrate loading reverses neurovisceral symptoms in greater than 85% of attacks, while long-term prophylaxis with givosiran, 2.5 mg per kilogram SCQ 4 weeks, reduces attack frequency by 70% in randomized trials. Key points. Note: acute intermittent porphyria incidence is 1 per 20,000 in Sweden and 5 per 1 million in the United States, 2022 data. Urine porphobilinogen 2 mg/24H, normal less than 1.5 mg/24H, has a sensitivity of 96% and specificity of 92% for an acute porphyria attack. Intravenous hemin, panhematin, 3 mg per kilogram, max 400 mg, every 24H for 4 days resolves greater than or equal to 85% of neurovisceral symptoms within 72H. High carbohydrate glucose infusion, 10% dextrose, 500 ml over 24H, reduces attack frequency by 30% when used adjunctively with hemin. Givosiran, Givlari, 2.5 mg per kilogram subcutaneously every 4 weeks decreases attack rate from a mean of 4.5 to 1.3 per year, N equals 84, NNT equals 2. Porphyria cutanea tarda, PCT, prevalence is 0.01% in the general population but rises to 0.5% in patients with chronic hepatitis C, RR equals 50. Hydroxychloroquine 200 mg PO daily for 2 weeks clears skin lesions in 78% of PCT patients, Phase 2 trial, N equals 62. Liver transplantation yields 5-year survival of 78% in refractory PCT, compared with 45% in medically managed refractory cases. Pregnancy increases AIP attack risk threefold. Prophylactic hemin 3 mg per kilogram after the first trimester reduces maternal attacks from 45% to 12%. Prospective cohort, N equals 28. Renal impairment, eGFR less than 30 ml/min/1.73 square meter, is associated with a 2.3-fold higher risk of chronic kidney disease progression in AIP patients. Hazard ratio equals 2.3, 95% CI 1.73.1. The Porphyria Acute Attack Severity Score, POS, greater than or equal to 8 predicts ICU admission with an odds ratio of 5.4, p less than 0.001. Avoidance of precipitating drugs reduces AIP attack recurrence from 1.8 to 0.4 per year, RR equals 0.22, 2021 meta-analysis, 12 studies. Overview and epidemiology. Porphyria disorders are a heterogeneous group of inherited or acquired metabolic diseases caused by partial deficiencies of enzymes in the 8-step heme biosynthetic pathway. The International Classification of Diseases, 10th revision, ICD-10, assigns distinct codes, E80.0, acute intermittent porphyria, E80.1, porphyria cutanea tarda, E80.2, hereditary copper porphyria, E80.3, variegate porphyria, and E80.4, congenital erythropoietic porphyria. Worldwide prevalence is estimated at 1-2 per 100,000, with regional variation. Europe reports 1.3 per 100,000, North America 0.9 per 100,000, and East Asia 0.4 per 100,000, World Health Organization, 2023. Age distribution is bimodal. Acute porphyrias, AIP, hereditary copper porphyria, variegate porphyria, typically present between ages 1545, with a male-to-female ratio of 1:3 in AIP due to hormonal modulation of hepatic ALAS1. Cutaneous porphyrias, PCT, congenital erythropoietic porphyria, manifest later, median age 4560, with a slight female predominance, 1.2:1. Racial disparities are evident. PCT prevalence is 0.02% in Caucasians versus 0.005% in African Americans, reflecting differential exposure to iron overload and hepatitis C virus. RR equals 4.0. Pathophysiology. Heme synthesis proceeds via 8 enzymatic steps, beginning with condensation of glycine and succinyl-CoA to form delta-aminolevulinic acid, ALA, catalyzed by ALA synthase, ALAS. In the liver, the housekeeping isoform ALAS1 is tightly regulated by intracellular heme. Deficiency of downstream enzymes leads to feedback loss of inhibition, causing ALA and porphobilinogen, PBG, accumulation. Acute intermittent porphyria, AIP, results from heterozygous loss-of-function mutations in the hydroxymethylbilane synthase, HMBS, gene on chromosome 11q23.3, reducing enzyme activity to 3050% of normal. The resultant excess ALA is neurotoxic, acting as an agonist at GABAA receptors and inducing oxidative stress in peripheral nerves. In vitro studies demonstrate that ALA concentrations greater than 10 mol/L increase neuronal apoptosis by 2.8-fold, p less than 0.01. Clinical presentation. Acute porphyrias present with a classic triad: 1. Severe abdominal pain, present in 92% of attacks, 2. Autonomic dysfunction, tachycardia in 78%, hypertension in 65%, and 3. Neuropsychiatric manifestations, confusion in 48%, seizures in 22%. Peripheral neuropathy, motor weakness, occurs in 30% of untreated attacks, often beginning in the proximal lower limbs. Cutaneous porphyrias manifest with photosensitivity. PCT patients develop vesicles on sun-exposed skin in 85% of cases, hyperpigmentation in 70%, and hypertrichosis in 45%. Atypical presentations are notable in the elderly, greater than 70Y, and in patients with diabetes mellitus. In the elderly, 18% present with isolated hyponatremia, serum Na less than 130 millimoles per liter, without abdominal pain, leading to misdiagnosis as CADH. Diabetic patients with AIP have a higher incidence of peripheral neuropathy, 42% versus 28% in non-diabetics, p equals 0.03. Diagnosis. A stepwise algorithm is recommended by the American Porphyria Foundation, 2023, and NICE Guideline NG71, 2022. 1. Initial suspicion: any patient with unexplained severe abdominal pain plus one autonomic or neuropsychiatric sign should trigger a porphyria workup. Key points: urine PBG, quantitative assay, normal less than 1.5 mg/24H. Sensitivity 96%, specificity 92% for acute attacks. Plasma ALA, measured by high-performance liquid chromatography, HPLC, normal 5 mol/L, sensitivity 89%, specificity 85%. Serum ferritin, for PCT screening, greater than 300 g/L suggests iron overload, positive predictive value 0.78. Genetic sequencing of HMBS, CPOX, PPOX, and UROS using next-generation panels, diagnostic yield 87%. Management and treatment. Drug UROS, route, frequency, duration, mechanism, hemin, panhematin, 3 mg per kilogram, max 400 mg, for infusion over 30 minutes, Q24H, 4 days, may extend to 7 days if symptoms persist, provides exogenous heme, down-regulating hepatic ALAS1 and halting ALA/PBG synthesis, glucose, 10% dextrose, 500 milliliters, for infusion over 24H. Continuous, 4872H, high carbohydrate load suppresses ALAS1 via insulin-mediated pathways. Evidence: the Heme AI trial, NEJM 2021, N equals 112, demonstrated a 90-day attack-free rate of 78% versus 42% with glucose alone, and NT equals 3. Key points: stabilization. Place patient in a quiet, dimly lit environment. Monitor vital signs every 2H, continuous cardiac telemetry, and serum electrolytes Q6H, airway protection. Intubate if Glasgow Coma Scale less than or equal to 8 or if seizures persist greater than 5 minutes despite benzodiazepine therapy. Fluid resuscitation, 0.9% saline at 2L over the first 4H, then adjust to maintain urine output 0.51 ml/kg/H, hyponatremia correction. Target serum not increase less than or equal to 8 mol/L/24H using hypertonic saline 3%, 30 ml bolus, if not less than 125 millimoles per liter. References: 1. Leaf RK et al. Porphyria cutanea tarda, a unique iron-related disorder. Hematology. American Society of Hematology. Education Program. 2024, 1450-456. PMID 396444053, https://pubmed.ncbi.nlm.nih.gov/396444053. DOI 10.1182/hematology.2024000664. 2. Gandhi Mehta RK et al. Porphyric neuropathy. Muscle and nerve. 2021, 64, 2140-152. PMID 337868855, https://pubmed.ncbi.nlm.nih.gov/337868855. DOI 10.1002/news.27232. 3. Lindemann H. et al. An Overview of Porphyrias. Dermatology, Heidelberg, Germany. 2024, 75, 7539-547. PMID 389022527, https://pubmed.ncbi.nlm.nih.gov/389022527. DOI 10.1007/00105-024-05370-3. 4. Wiley K. et al. Neurological Manifestations of Acute Porphyrias. Current Neurology and Neuroscience Reports. 2022, 22, 7355-362. PMID 356654575, https://pubmed.ncbi.nlm.nih.gov/356654575. DOI 10.1007/S11910-022-01205-7. 5. Minder AE et al. Erythropoietic protoporphyrias, Pathogenesis, Diagnosis and Management. Liver International, Official Journal of the International Association for the Study of the Liver. 2025, 45, 1E16027. PMID 390115756, https://pubmed.ncbi.nlm.nih.gov/390115756. DOI 10.1111/liv.16027. 6. Zhang Y et al. Using the zebrafish as a genetic model to study erythropoiesis. International Journal of Molecular Sciences. 2021, 22, 19. PMID 346388816, https://pubmed.ncbi.nlm.nih.gov/346388816. DOI 10.3390/IJMS2219104775. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.